effort. That is something which has to be appreciated. Lot of effort has been.
It looks sometimes, it looks sometimes biased, sometimes it looks unbiased. But in that, madam, checks and balances, everything is checks and balances, so that nobody should feel offended, nobody should feel that they are related. Including one term, president one term, secretary. So nobody should feel that, if you have been equal, madam.
And everybody should voice their opinion also, so that is fine.
The next generation, madam, now, next generation aggressive madam. Futuristic
madam, in the meeting, actually 99% of the things which we could go with consensus. Highlighted.
Correct.
When even the difference of opinions are actually very important. Because that's discuss madam. The way forward, we should have an idea, ma'am.
Yeah, it was well thought out.
Shall I just say time?
I think it's already 5:05.
Yeah, we can get started. Yeah, we can get started.
Yeah. Deepti joins,
my seniors and friends. I'm Dr. Reshmi, Cochin Obstetric and Gynecology.
Before Reshmi starts, just wanted to check whether are we online?
Yeah, we are online.
Fine.
It looks like. Yeah, I think we can see that YouTube thing.
Yeah, YouTube thing can be seen. It's being sent to you.
I didn't see that. Usually a message verle. You are live.
We are recording, Kim.
Usually recording YouTube it will be there.
Okay. Fine. The YouTube thing anyway is being shown.
Yes, it's been
so that should be okay, right?
Yeah, it is there in the YouTube. I just checked.
Yeah, that icon is anyways.
Instead of instead of recording and uploading, this is the best thing.
Yes.
Shall we start?
Yeah. Reshmi,
again,
you can start one more time.
I am Dr. Reshmi, Treasurer, Cochin Society. It's my proud privilege to be the MOC today of Kfog Edge webinar series by Research Committee of Kfog, this journal club. When my dear friend Dr. Shaijas is the chairperson of the research committee, we all expect nothing less than sheer brilliance, and he has never let us down and continues to inspire us. So, let me formally invite Dr. Shaijas, the chairperson of the research committee, for the formal welcome address. So, we all know that he has been the past chairperson of Midlife Management Committee, FOXY, Chair Research Committee of Kfog, past President Canonor OG Society. He is a social reformer and an award-winning film director. Champion of women empowerment. Over to you, Shaijas.
That should be okay, Reshmi. Thank you so much. Thank you. First of all, thank you so much on behalf of the research committee. It is such a pleasure to have the Kfog Edge webinar series number 19. As you all know, is the brainchild of Dr. Kunjumoideen, the present president of Kerala Federation. So it was his idea that we divide the societies into 3 zones and we discuss very important articles which could be of relevance for the practicing OB-GYNs. So it's a privilege for me to do the welcome address for this particular edition of the Journal Club by the Research Committee of Kerala Federation. It's my privilege to welcome the Kfog President, Dr. Kunjumoideen, to this gathering. Thank you so much for all the effort that you've taken to ensure that the programs of the individual committees have been streamlined and it is being of benefit for the practicing OB-GYNs across the state. So welcome Dr. Kunjumoideen to this gathering.
Yeah, thank you.
I also take this privilege to welcome the Kfog Secretary General, Dr. Subhash Malya. Thank you for taking time out and being a part of this journal club of the research committee. Thank you, Subhash, for coming in, and congrats on all the wonderful effort that you have been doing over the last 1 year, and the tenure continues. Hope we can bring about a lot of good changes in the organization with your efforts, along with the respective president of the Kerala Federation. I welcome Dr. Subhash to this gathering. Also, my privilege to welcome Dr. Sujitra Sudhir, who is the state coordinator of the Kfog Edge series. Madam is also, as you know, the incoming president of Kerala Federation, and I'm sure that the organization would reach greater heights under Madam's tenure in the year to come. I also welcome the presidents of societies that are being part of this particular series. Dr. Gracie Thomas, the president of the Cochin ONG Society, Dr. Bindu, the president of the Thrissur ONG Society, Dr. Chandrasekhar Naik, the president of the Malanad OB-GYN Society, Jessie Madam, the president of the Angamali Society, and Dr. Emi, the president of the Palakkad ONG Society. So I welcome all the presidents to this particular gathering. Thank you so much for your coordination, and it's always a pleasure to associate with these individual societies which are doing wonderful work both on the academic and the non-academic front. Also, my privilege to invite the first presenter of the day, Dr. Deepthi Surendran from Palakkad. I also take this privilege to welcome the experts for the first session. Dr. Elizabeth Joseph from Angamali, Dr. Reshmi from Thrissur, Dr. Agnes Matthew from Malanad Society. Welcome all three of you as well as the presenter to this particular gathering. Also take this privilege to welcome the presenter for the second session, that is Dr. Atulya from Thrissur, as well as the experts, none other than Serena Gilbas Madam, as well as Radha Madi Madam. I welcome all of you to this particular gathering. I also take this privilege to welcome the MOC for the day, Dr. Rishmi. Rishmi is from Kerala, has been doing some wonderful work for both Kfog as well as Foxy. Rishmi continues doing the good work, and thank you, Rishmi, for consenting to be the MOC for this particular gathering also. Also, my privilege to welcome each and every one of you who has gathered and logged in from far and near for this particular webinar series, the Journal Club of the Research Committee of Kfog. I hope you'll find it academically useful, and we'll have some very clear take-home messages to help you practice OB-GYN in the best manner possible. Over to you. I take this privilege. Rashmi, can we have the CV slide of Dr. Kunjumoideen? Yes. So, as you all know, Dr. Kunjumoideen is the present president of Kerala Federation with 27 plus years of experience in the field of reproductive medicine and gynecendoscopic surgery. He's been the medical director at present of Birla Fertility and ARMC IVF, the senior consultant at Perindalmanna and Kozhikode, the member of the board of directors of the Birla Fertility and ARMC unit, and the chairman of the ARMC Aegis Hospital. He's a visiting consultant and IVF specialist at Modern Al Salama Medical Center at Muscat. He works at Oman and the KIMS Health at Dubai also. The former chairperson of ISAR Kerala chapter, the founder president of the Perindalmanna ONG Society, did his graduation from Thrissur, the post-graduation from JIPMA Pondicherry, has been an invited faculty at various national and international conferences and has authored various chapters. So welcome Dr. Kunjumoideen for the presidential address and to inaugurate this particular journal club of the Research Committee of Kerala Federation.
Yeah. Good evening all. Dear Dr. Shaijas, the chairperson of the Research Committee of Kfog, Dr. Subhash, the Secretary General of Kerala Federation, Dr. Serena ma'am, the past president of Kerala Federation and a senior teacher, Dr. Radhamani ma'am, a senior teacher, and I still remember the affectionate advices and the support she has given during our Justicon conference. All the senior faculties, Dr. Reshmi, Dr. Elizabeth, and Dr. Deepthi, and all the faculties and the experts who have been here, and the presidents and secretaries of all the member society participating societies, and the dear delegates. The journal club, actually, can you stop sharing the CV?
Rishmi?
Journal club is actually a brilliant concept for the research committee. Actually, apart from all that makes actually different from all the academic activities Kfog is conducting, journal club is something which is actually an academic activity for the future. Because really, when we go through a lot of journals, it is very disheartening to know that the articles from a country of 146 crore population is almost lacking. When a lot of the organization and associations, when they bring about Indian guidelines, you can see Indian guideline on PCO, Indian guideline on endometriosis. But when you look at the article with which they have made these guidelines, actually it is what to say, it's a very sad state of affair that we have made Indian guidelines based on the studies done on the foreign population. So actually, it is not the problem with the people who have made the guidelines, but it is the concept behind those guidelines, where initially, before going for such guidelines, we need to have a lot of journal clubs where we should be familiar with the statistical methods, the method of studies, the concept for various research proposals. So very often when we tell the fellows to do some research activities as a mandatory part of their fellowship program, they often come back and tell us that they don't have any novel topics. So, to my feeling, I say everything in the clinical medicine of obstetrics and gynecology can be a topic for research. It need not necessarily be some new drug or new treatment or something. Everything which you add value to any type of treatment, because the treatments and modalities are constantly evolving and changing. So, Journal Club is the first step towards that movement. I, I I can say that that should be a great movement from the people who are working at present. We, the specialists in obstetrics and gynecology, we need to go ahead with a lot of research activities, and that should be the foundation stone for a guideline to be prepared by the KFOG 10 years later down the line, with these articles from our own land of India, that we need to come out with our own guidelines. So where the research is the founder stone, and the research committee, this journal club, I humbly request our chairperson, Dr. Shaijas, to continue with this, because my tenure as the president of KFOG will be over in next coming few days. By next Saturday, I'll be handing over this my tenure to the next incoming president. I request the chairperson to continue with the journal club, not once in three journal clubs in a year, rather on a fixed day of every month. We don't mind how many people join. Many people won't be there for such sort of activities. That's not an issue at all. Those who want to come up in this research field, they will definitely be there with us. They need not be from an academic institution. They can be from any private institution they're working. So I wholeheartedly request the chairperson to continue with this activity in the coming 2 years as well. And with these few words, I formally inaugurate this today's webinar, and wish all the best for all the faculties, experts, and the delegates who are going to listen, and let this may be an enriching knowledge practice for you all. Thank you.
Thank you. Thank you so much, Dr. KM. I think the point that is well taken, and in presence of the President-elect, Dr. Sujitra Sudhir Madam, I hope we can continue this activity. As you rightly said, irrespective of the number of the people who actually log in, I think whoever decides to log in and whoever is able to find out time from their busy schedule, I'm sure that they are getting academically benefited. There's been a lot of personal DMs that have come in even after the last journal club sessions on how beneficial it has been. And I hope with so much of academically brilliant individuals, including both seniors and those ones which are belonging to the present generation, I hope this will provide a perfect platform for people to get academic benefited. I think we are always, gynecologists are always blamed that we hardly get any time to read and update ourselves because we are busy running from one hospital to the other, catching babies one after the other. And this is a blame that we have been bearing from the time of our postgraduate days. I hope it is definitely time to change, and we are very intellectually wonderful people. I think we have the ability to think and act and discuss and analyze and do a lot of things just like any other specialty in medicine. And I hope this will be a perfect opportunity to make people understand that we are also the updated lot who does such journal clubs. So thank you so much, Dr. KM, for those wonderful inputs. It's been a pleasure to get this year started under your guidance, and I am sure under Sujitra Madam's guidance, this particular initiative will continue in the days to come. Next is my privilege to introduce Dr. Subhash to this gathering, the Kfog Secretary General. Can I just have the CV? Yeah. Subhash, as you all know, is the Kfog
Thank
Secretary
you, Tejas.
General. Yeah, Subhash, just
Thank
2
you.
lines.
Thanks
I
a
think you
lot.
should
Thanks a
permit
lot.
just 2 lines. Just 2 lines. Yeah. Yeah, he just finished his tenure as the endoscopy committee chairperson of FOXI, awarded the best committee award for the wonderful activities that he did over the last 3 years. So without taking much time, I welcome Dr. Subhash. I would request you to, I think you should park your vehicle before you start talking to us. Thank you so much, Subhash. On a lighter vein was that. Thank you so much for joining in, and we would love to hear from you. Over to you, Subhash.
Thank you very much. As you have rightly said, I've parked my vehicle here. Right. Thank you very much for the kind words. At the outset, let me thank the president and all the members, present secretaries of all the societies for the wonderful opportunity. Again, Shaijas, I too am not very well versed in the journals, and I'm actually trying to learn down. I've actually gone into the FOXI website, and I'm trying to learn about this, because this is one place where I believe I have not. There are many places where I've not done well, but this is actually one of the things which I think I should be doing well. I should learn well, and I would definitely be trying to follow this, at least not for today's one, because I'm actually entering the forest, so I will not get the signal now. But what I would like to share with all of you here is Dr. Kunju Moideen is our candidate for the Clinical Research Committee of FOXI for the year 2025 to 26. Yes. So I request all the seniors here to please support Dr. Kunju Moideen in his endeavor for FOXI Research Committee, Clinical Research Committee. In the meantime, what has happened is in FOXI, there is no representation of Kerala, a state which has always been very at the forefront of all the academic and all the maternal and the health issue, concepts in this country. We do not have any representation in FOXI now. Now that me and Shaijas have been, we have finished our term. So I request all the seniors to kindly bless and help Dr. Kunju Moideen to be the chairperson of the clinical research of FOXI. Okay? And with these words, I would like to congratulate Shaijas and the whole team for this wonderful work that they have done. And we'll carry on with the academy. Thank you very much. Thank you.
Thank you, Subhash. Thank you, Subhash, for those kind words. And I'm sure that once Dr. KM gets into this clinical research committee at the national level, I think it will be a perfect coordination between the state and at the national level, and probably we can do much better research on a wider basis. And I hope that dream will materialize. So I'm sure that all of us will support Dr. KM for that tenure and for that post. Thank you, Subhash, for those kind words. Next, I take this privilege to get in Sujitra Sudhir Madam, the President-elect of Kfog, as well as the coordinator for this entire Kfog EDGE webinar series. Sujitra Madam, as we all know, has been a very senior member and a very active member of the Kannur ONG Society, has been the president of the Kannur ONG Society, has been the adolescent chairperson between 2015 to 18, has been the vice president of Kfog in 2020, has been the editor of the Kfog journal between 21 to 23. So on that note, let me welcome Sujitra Madam to this gathering, and let us hear a few words of blessings from Sujitra Madam. Over to you, Madam.
Thank you, Dr. Shaijas. Dr. Shaijas is a person who is always a perfectionist. He's a versatile person, and whatever he does is absolutely wonderful. So I think our president, Dr. Kunju Moideen, really selected the best person for this particular portfolio. And I'm sure he will continue with it in the coming years also. And by the way, I would like to say something else. I am requesting Dr. Kunju Moideen, our president, to carry on this Kfog webinar series next year also, because he is the right person who can really chart out the way the things are being done. So, Dr. Kunju Moideen, I hope and pray that you will take up my suggestion of being the Kfog webinar coordinator, if you don't mind, next year. So I'm sort of passing the ball into your court, and I'm sure all these things will go on well again. And all the best to Dr. Shaijas, Dr. Subhash, and all those gathered here today. So thank you so much. Carry on with the webinar.
Madam, with your suggestion and the expression that is there on KM's face, he's finding himself on the edge.
Absolutely, absolutely.
Actually, he told me he will take up that. So I
I
know.
We were just kidding. I'm sure that he's going to be there. And there's a lot of good coordination that he'll be able to do and contribute in your year also. Thank you. Thank you so much, madam. I am sure that KM wants to say a few words on that.
Yeah, actually, I'll be there 200% to support Dr. Sujitra ma'am, because it is our all responsibility to support madam to do so much activities in the next coming year, so that Kfog will be in high flying colors. All support,
Thank you
madam.
so much.
Yeah.
Thank you so much.
Perfect. Perfect. So on that note, I think there's a lot been, reallocation of posts and responsibilities that has been done during the welcome address and this gathering. So a lot of good things. Wonderful. So on that note, let me hand it over to Rishmi. And we'll hear a few words from the presidents too. Naik sir is there. Naik sir, a few words
Yes,
of blessing from you.
First of all, I would like to thank Kfog and its journal club involving Malanadu in this program. This year we had many web series and journals clubs in this platform, which were very useful to us. Thank you, Kunyamudin sir, Subhash sir, Shaiju sir, and Suchitra madam, and Rashmi madam for this web series. I hope today's topics are very useful for us and informative also. I wish all the best to Kfog Journal Club and Deepthi madam and her team, and Atulya madam and her team.
Thank you. Thank you so much, Naik sir. Wonderful to hear from you. And I think I can hand it over to Rishmi now, because I'm unable to find the other presidents for their address. So,
Yes,
Rishmi, you can take up the proceedings.
I think Dr. Emmy is online, Palakkad Society.
Is she here?
Yeah. Emmy, can you say a few words?
Good evening.
Yes.
Greetings from Palakkad Society, respected seniors and friends. As Kunjumuddin sir has rightly told, this is a special special thing, this journal club, apart from all, special from all other webinars and all. And I wish from Palakkad Society, and personally, I wish all the best for the in this endeavor.
Thank you. Thank you so much, Dr. Amy. Is there anybody else here? Dr. Jissi?
Dr. Jissi told that she'll be there. Madam, are you here? Dr. Jissi?
Jissi madam, are you here? Okay, I don't think so. Dr. Bindu, is Bindu madam here?
Bindu madam was traveling. Bindu madam and Gracie madam had told that they may not be.
So I think we'll get on with the session. Rishmi, to take up the proceedings. Yeah.
Thank you. So let me, for the first session, moving on to the academic session, let me introduce the experts to the first session. Dr. Elizabeth Jacob, Senior Consultant in HOD, Apollo Adlex Hospital, Angamali, Cochin. Madam is a member, Foxy Vaginal Surgery Committee from 2024-25, National Joint Secretary, Society of Vaginal Surgeries. As we all know, Madam is a top academician. She is the recipient of Kalyani Devi Memorial Award for Best Paper from Kfog. Madam is a recipient of FIGO and IPAS Award for Best Papers in FIGO World Congress, Vancouver. Her areas of interest are vaginal surgery, high-risk pregnancy, and postgraduate teaching. It's my privilege to introduce Dr. Rishmi Madam. Madam is a Secretary, Thrissur OBG Society and RCOG Kerala Chapter, MRCOG examiner, and Madam has been the gold medalist of Best Outgoing Postgraduate from Government Medical College, Calicut, with interest in quality improvement in healthcare and high-risk obstetrics. Next is Dr. Agnes Madam. Madam is a doctor with experience spanning more than 40 years and medical teaching of more than 20 years. Madam is a member Foxy for 38 years, Charter President, Malnadu Obs and Gynec Society, first captain, MD MNSR PDK. Madam is a skill trainer at TOPS and Kfog as co-director. Madam is passionate about preventive and positive health. I request Dr. Reshmi C.R. Madam to introduce the presenter, Dr. Deepan Surendran from Palakkad.
Yes. Thank you, Reshmi. So it's my, I'm Dr. Reshmi speaking. It's my proud privilege and so happy to introduce my own student, Dr. Deepthi. She was my undergraduate student, postgraduate student, and during her postgraduate years, I was her PG teacher. That means one PG is assigned a teacher and her thesis guide. She was one of our undergraduate topper. She she had a rank holder in MS postgraduate exam in KUHS exam, and she's a very brilliant, hardworking, dedicated professional who won the 2021 Young Talent Award of Kfog. She did her FNB in reproductive medicine from SIMA, Edapar, and is currently working as a consultant in Nova IVF Fertility Palakkad, and she's a member of Palakkad OBG Society. And over to you, Deepthi.
Hi, ma'am.
I think before that, I think we'll take the opening remarks. Reshmi? Reshmi, you need to unmute yourself. I mean, the two Reshmis. The
It's
MOC
Reshmi.
Reshmi.
Okay.
Reshmi, you can unmute.
Madam, to give the opening remarks on the topic. I think I'm audible. Elizabeth, Madam?
Reshmi,
Yes.
Madam?
Me?
Yes.
You wanted me to?
Yeah.
Okay. At the outset, I think I have to congratulate Dr. Kunjumoideen, Dr. Shaijas, Dr. Subhash for planning this Kfog webinar series. And like Kunjumoideen said, I think research is an area where the interest has to be ignited at the level of the medical colleges and further on into the clinician life. Because once we start practice, we are often out of guard of it. And I think this will actually ignite that interest in each of us to start off with some small research as possible. Now, regarding this topic, I think Reshmi has introduced the speaker. I think we have a brilliant speaker here today to highlight on this very relevant topic. We have always considered that hypertensive disorders in pregnancy and gestational diabetes are one of the most common medical disorders in pregnancy. And gestational diabetes accounts for about 15% of incidence in our part of our country. So the effect that it has on the maternal health is very well documented. And as far as the fetal health is concerned, that is also very much documented. But what happens to these children when they grow up? I think that's been very less studied. And this is one such study which will shed some light or some insight into what exactly goes on in utero and how relevant it is that the preventive aspect of the babies born to them and also the in utero control will have on the outcome for these children who are born. But of course, there are definite limitations to this study, and I think as we go through the presentation, we'll be able to find more insights into it. Over to you, Deepthi, for your presentation.
I think I will be sharing Dr. Deepthi's presentation because she's unable to share it from her side. When Reshmi was telling, I was just thinking, earlier days, it used to be a privilege for the student to get an opportunity to introduce her teacher. Now generations have gone by and we take it the other way as the privilege now.
Yeah,
exactly, sir. I would like to thank you, my dear teacher, Reshmi ma'am, for this. It was very kind of you to tell those words. And I would like to express my gratitude, ma'am. It's like your guidance and mentorship was always so much helpful in my journey. And without your support, I wouldn't be here. And to all my teachers in Trishul Medical College, actually, the way we used to try to implement the evidence-based practice in our labor room and wards, and it was so inspiring. And I'm still taking it along my practice. Thank you, ma'am, again for such kind words. And thank you, Kfog and Palakkad OG Society for giving me such a wonderful opportunity. I would like to begin. Okay, so the title of today's study is
Deepthi, you can continue your presentation and you can tell change whenever you're finished with telling the matter from that slide.
No, sir, I'm sorry for the inconvenience.
No, that is okay. You can just tell me change slide and then
So
I'll
the title, okay, sir. Title of the study is Impact of Hypertensive Disorders of Pregnancy and Gestational Diabetes Mellitus on Offspring Cardiovascular Health and Early Adolescence. Change. And this study investigates how hypertension and diabetes affect the cardiovascular health of children when they reach adolescence. And it is a very important research because it studies about these very common complications during pregnancy and how it can have a long-term effect on a child health. And about the journal, sir, please click. It's AJOG, as we all know. It is the well known as a Gray Journal, and it is one of the most respected journal in the field of OG, obstetrics and gynecology, and it has a high impact factor of 8.8. The study was conducted by Venkatesh et al. Objective of the study was to examine associations of hypertensive disorders of pregnancy or gestational diabetes with offspring cardiovascular health in their early adolescence at the age of 10 to 14 years. Sir, change. So this was a prospective cohort study. So this is a type of observational study in which the researchers follow up a cohort of people over a time and observe their outcomes. And this study used data sourced from HAPO study and HAPO follow-up study, which was conducted from 2000 to 2006 and 2013 to 16 respectively. So briefly, the HAPO study was a population-based study to examine associations between pregnancy dysglycemia and adverse pregnancy outcomes conducted between 2013 to 16, and the follow-up study examined association of GDM with long-term cardiometabolic outcomes of postpartum individuals and their children when they were aged 10 to 14 years. Population was 3,317 mother-child dyads from 10 international field centers. Next slide, sir. Next slide. So exposures were hypertension, gestational hypertension or preeclampsia, which was on the basis of the diagnosis was based on the basis of guidance from International Society for Study of Hypertension Pregnancy Guidelines. That is, preeclampsia was diagnosed when the systolic BP was more than 140 or diastolic more than 90 millimeters of mercury on 2 occasions in a minimum 6 hours apart, and proteinuria of 1 plus dipstick or more than or equal to 300 milligram per 24 hours. If the criteria of elevated BP alone but not proteinuria were met, a diagnosis of gestational hypertension was established. Next slide. Diagnosis of GDM was made using the IADPSG criteria, consisted of the following 75-gram OGTT result: fasting more than or equal to 92, 1 hour plasma glucose more than or equal to 180, and 2 hour more than or equal to 153 milligram per deciliter. Next slide, sir. So, women with pre-gestational diabetes, chronic hypertension, preterm births, and severe congenital anomalies were excluded. Next slide. So this was the participant inclusion flow chart. So can you just click for the animation? Yeah, so this is the population inclusion flow chart. Initial population was around 4,685, and women with chronic hypertension and insufficient data were excluded, and the final included population was 3,317. And the next table shows characteristics of included versus excluded participants. So the mean age of participants included was 30.4 years, and the mean gestational age at enrollment was 27.9 weeks, and gestational age at delivery was 39.9 weeks. So preterm delivery were excluded. Next. Next. So total included participant 3,370 mother-child pairs, and the prevalence of HDP among them was 9.3%. Prevalence of GDM was around 12.7%. Next slide, sir. So outcome measurement. Outcome was the offspring's cardiovascular health, and it was assessed using the 4 metrics or indicators, that is BMI, body mass index, blood pressure, cholesterol, and glucose. And these indicators were categorized as ideal, intermediate, or poor, depending on AHA framework. Sir, can you just click for that table? Yeah, so this table, it is showing that each category was divided into poor, intermediate, and ideal. Ideal was given a score of 2, intermediate 1, and poor 0. So total score was ranging from 0 to 8, with 8 score having all ideal or all good, and more than or equal to 1 intermediate, 1 poor metric, and more than or equal to 2 poor metric. So these were the 4 mutually exclusive categories. Next slide, sir. So coming to offspring data, the median cardiovascular health score was 7 out of 8. That is, 54.5% of the children had more than or equal to 1 non-ideal cardiovascular health metric. So let us see the association of hypertension and diabetes with each CVH metric. Sir, can you just click? Yeah, from this table, we can see that they have mentioned the adjusted risk ratio. That is, a risk ratio of more than 1 means there is increased risk for that specific CVH issue. So as we can see, in hypertensive disease of pregnancy, BMI, that is the child's BMI, there was a risk ratio of 1.32. That is, children of mothers with history of hypertension were having 1.32 times risk of having a higher BMI. That is the meaning of that. And the risk for high BP, there was a slight increase, but there was no statistical significance. And there is no major effect on cholesterol or glucose levels in children. So takeaway is that hypertension in mother is strongly correlated to high BMI in children, and effect on the high blood pressure or glucose is unclear, and there was no effect on cholesterol in the kid. Coming to GDM and child cardiovascular health, children have 1.2 times, that is about 22% higher risk of elevated BMI if their mother had GDM in pregnancy. And high BP and high sugars in children, there was a slight increase, but again, it was not statistically significant, and there was no effect on cholesterol level. Take home, GDM is also associated with higher BMI in children, but its effect on BP and glucose level are not well, established. And to summarize the findings, both hypertension and gestational diabetes mellitus increase the risk of high BMI in children, which can contribute to their adverse cardiovascular problems. So next slide. So this is association of overall adverse cardiovascular health, that is combined BMI, cholesterol, BP, and everything. So if the mother had hypertensive disease in her pregnancy, there was 1.1 having an adverse cardiovascular health outcome. And GDM, if the mother had GDM, risk ratio was 1.10 for the child to have an adverse cardiovascular health outcome. And stronger associations were there with severe adverse CVH metrics. That is when there was more than or equal to 1 poor metric. Next slide, sir. Yeah, this is to summarize the result. Both hypertension and diabetes increase the risk of higher BMI in children, which can contribute to adverse cardiovascular health. And trends on offspring's BP and blood sugar levels are less clear, but it may cause a possible risk. Next slide, sir. So clinical implication, this shows importance of screening and management of hypertensive disorder of pregnancy and GDM during pregnancy, and early cardiovascular health intervention for at-risk children like diet and activity. Next slide. And the study also gives some points for future directions, like study mechanisms linking hypertension and diabetes to offspring cardiovascular health, like epigenetics and placental dysfunction, and to assess cumulative risk of multiple adverse pregnancy outcomes, and to explore interventions targeting both maternal and child health. Next slide, sir. Conclusion of the study: maternal hypertensive disease in pregnancy and gestational diabetes mellitus significantly increase offspring risk of suboptimal cardiovascular health in adolescents, and reducing adverse pregnancy outcomes and implementing early intervention can improve lifelong health outcomes. Next slide, sir. So I would like to proceed with critical assessment of the journal. About objectives and rationale, the strengths were that the objective was very clear, addressing the impact of HDP and GDM on offspring CVH, and it highlights the fetal metabolic programming as a critical determinant of health. Weakness of the objective, there was limited exploration of racial and ethnic disparities influencing outcomes. So the most study population was mostly based on UK and US, and other population were actually not included much. Next slide. Critical assessment of study designs and methods. Strengths. It was a large, multinational cohort enhances generalizability, and there was standardized CVH metrics using the American Heart Association guidelines, and it was adjusted for key confounders like parity and maternal age. Weakness. Exclusions like PGDM or chronic hypertension. Sir, previous slide, please. Yeah, exclusions like PGDM or chronic hypertension may underestimate effect, and there was no analysis of postnatal environmental factors like diet and the kids' activity, socioeconomic status, which are very important, especially in factors like obesity. Next slide, sir. About results and data presentation, strengths were that there was clear associations between maternal hypertension GDM and the offspring CVH, especially BMI, child's BMI, and there was effective use of figures and tables for data visualization. Weakness was that there was wide confidence intervals for severe CVH metrics, especially in the columns like the baby's hypertension and blood glucose levels. Next slide, sir. About interpretation and limitations. Strengths. It correlates findings with prior research on fetal programming and CVH, and there was clear implications for maternal child health. Weakness, there was limited exploration of alternative mechanisms like shared genetic predispositions, and interaction between the hypertension and diabetes was not explored. Next slide, sir. So I would also like to mention some of the similar studies. Can I proceed?
Yes, Diti.
Okay. So this was a HAPO and HAPO follow-up study. It examined the impact of maternal GDM and blood glucose levels on offspring, metabolic and cardiovascular health. And they found that higher maternal glucose levels, even below the GDM thresholds, were linked to increased childhood obesity, insulin resistance, and high BP. Next slide, please. So this was another study, the ALSPAC study, A1 longitudinal study of parents and children, that is Children of the 90s study. It tracked 14,000 mother-child pairs in UK since the early 1990s, examining links between maternal health, nutrition, and offspring outcomes. And they found that maternal obesity and gestational weight gain were associated with higher childhood BMI and metabolic risk. Maternal hypertension and poor diet were linked to higher BP in the offspring. Next study. That is the Generation R study, which was conducted in Netherlands. It followed up 10,000 mother-child pairs in Rotterdam from fetal life into young adulthood, and they found that maternal hypertension and diabetes were associated with higher child BP and arterial stiffness, and children of mothers with poor pregnancy nutrition had higher risk of obesity and even neurodevelopment disorders. Next slide, sir. And these studies confirm that maternal conditions like GDM, hypertension, obesity, and poor nutrition have lasting effects on offspring health, increasing risk for obesity, high BP, diabetes, and even neurodevelopmental disorders. With this, I would like to conclude my presentation.
Thank you, Dr.
Thank you, Diti.
Okay.
I request the experts to take over the discussion. Agnes Madam, Reshmi Madam, Elizabeth Madam.
I think Agnes Madam, would you like to give your comments first?
Yes, yes. At the outset, I must thank Dr. Shaijas for inviting me for a thing like Journal Club. And I must really congratulate Dr. Kunjumoideen for including Journal Club into the Kfog web series. Because as he said, actually research is much needed. Outside world, we know the number of cases are much more in our medical colleges, but we never keep a record and do research. So I wish Dr. Kunjumoideen all the best for him to become the national coordinator, the chairperson for clinical research, because there's a need, as he said, as well as an opportunity which we are not exploring at all. And this has to come from the major medical colleges, because it's not enough just to teach, but also like Reshmi will say, in our medical education, what do we say? Scholarship is very important, and letting people know what we are doing is also very important. And thank you, Dr. Deepthi. You have actually gone through the whole thing and compared with other studies. This study is this article as such, first of all, because we'll talk about the article, and you've analyzed it well, and you have brought out parallel studies also. One of the things is that the research implication of the epigenesis of diseases is well known. In fact, I really believe in that. And you can see that when mothers are not only obese, hypertensive, diabetic, or stressed, they have more complications than an ordinary normal BMI person walking in with no comorbidities, and their pregnancy is very smooth riding. So, what happens intrauterine? Definitely, the fetus will be affected. That is the epigenesis we are talking about. So, intrauterine fetal programming, as very well brought out by Deepthi in this study, the genetic as well as the lifestyle of the offsprings is not actually studied. Not, it is just compared with the disease of the mother. But even after birth, with the epigenetic factor in them, the genetic as well as the lifestyle, if it is analyzed and a wider group of people, or wider difference in the population studied, would have made this a very strong study. The other pregnancy outcomes are not compared, like preterm, and what happened at what gestation they were born, SGA, LGA. Those things are, maybe they have studied, but they are not in the article. Definitely, this is a very important aspect, the epigenetic aspect of uh, the diseases. And I hope and I wish that everyone should be doing looking at the woman who is entering, whether they are having a family history, whether they are obese, and early OGTT. And I think it is our responsibility to guide them. See, to have a disease is not smart. To prevent the disease is smart. That's what I would say. I will. Yes.
Elizabeth Madam and Rishmi.
Yes.
Yeah. I like Agnes ma'am said, I think Deepthi really elucidated the study piece by piece. I think she did an excellent work taking out every aspect and made it so crystal clear to us. I think I have to congratulate you, Dr. Deepthi, for it. And I'm
Thank
not
you.
surprised that you have been the topper and medalist and
Oh,
all that.
thank you, ma'am. Thank you.
That was very well evident from the way you prepared the slides. So,
Thank you.
apart from that, regarding the study, like Agnes ma'am said, yes, epigenetics is the basis of the study, and that's exactly what they wanted to bring out. But along with that, there were those few limitations actually limited to what exactly the outcome will have a clinical relevance to us. because the only main thing that came out was that the BMIs were higher in these kids, and that the overall cardiovascular risk could not be actually found out in regard to the other three parameters, because maybe they did not include the pre-gestational diabetic and the chronic hypertension women, who are actually having a higher epigenesis of causing these problems in these girls. That's one point. The other important point is that the severity of the disease has not been taken into account. They have not mentioned anywhere that what was the kind of severity of the gestational diabetes. What were those? How many patients of them were on insulin, or what was it? So that might have created a sort of a bias here. So that's another second point that probably, as whenever we do research or something, maybe we need to think about that. That's when we do a population, a cohort study like this. The third important point, I think ma'am highlighted that what happened after birth to these kids. Yes, epigenetic. Yes, we know they were exposed to the diabetic or the hypertensive environment of the mother, which predisposed them. But what happened to them between that till they reached the 10 to 14 years? We do not know what exactly happened to them. So that is a bridge gap that again actually creates a little bit of bias in this study. But overall, yes, it is an eye opener to all of us as clinicians. And another important thing was that what kind of a preventive step should we as obstetricians take from this study? What is it implying to us, that whether a better control would actually reduce the risk? Those are some points that we need to introspect as obstetricians to ourselves. I think these are the important points that came to my mind. Overall, an excellent presentation. I really loved listening to it, the way you presented. I have to say that. And congratulations, Shai, for bringing it. Actually, I was a little bit reluctant today. I had multiple things to do, but then I'm really happy I joined, because it was a really good presentation, and overall really enlightening. Thank you.
Thank you, ma'am.
Thank you, Agnes Madam. Thank you, Dr. Elizabeth, for those inputs. And thank you, Kfog and Dr. Shaijas, for this opportunity. It was an excellent thing. Actually, can I add on some points? So, as Kunjumudin sir told, every person should be doing an evidence-based medicine practice. And that person must know the art of looking into an article. And when you look at an article, how to make sense of that scientific evidence. So, actually, you brought out excellently that study, the limitations, the critical appraisals, everything was perfect. And again, when you look at an article, you have looked at it like introduction, the methods, the results, and the discussion. That is the IMRD, the IMRAD. That is there in the article. So whenever you look at an article, you look at like that. Is the introduction there? Is the methods there? Results, discussion. So if it is there, then it must be a good article. And there are many things we should look for. Is it a good impact factor journal and all? And also, when you look at an article like this, when you critically appraise, 6 questions you should ask. Does the study have a so I will ask you 6 questions, Deepthi. Does the study have a scientifically interesting and important aim?
Definitely, ma'am. Yes, it has.
Yes, it is very relevant because the very common hypertension, diabetes in our population. So it is very relevant, and you have to know it is going to affect the children. And will the study outcome provide a clinical significance to the reader? Yes, for us it is significant. It may change the whole way we look at our practice. And then the third question is, looking at the article, was the methodology well designed? So, looking at that article, the methodology was good. They had a large cohort of population and all, and they followed them up. It was good. The blinding was correct, and then they followed them up and all. Then, is the primary outcome variable properly evaluated? Yes, they looked at it as you have told. They looked at it and used the AHA criteria, so that is okay. Then, fifth question is the sample size large enough to find a reliable and meaningful difference or effect? What do you think about it, Deepthi? What did you think
And
when you
although
went?
the population studied was very large, but
Yeah,
in that incidence, I mean, prevalence of GDM and hypertension was not that much.
12%.
Yeah,
Actually, that is
12%.
exactly what I had to. I was actually surprised. Initially, when I started reading that journal, I thought it was 3,000 patients who were followed up. But it was the 3,000 population, 3,317 population who were included in the HAPO study. And of
Yes,
them, only 9.3% had hypertension and 12.7% had GDM. That means 345 patients with hypertension and 484 patients with GDM were followed up. So only they were following up 345 babies and 484 babies with hypertension and diabetes. So that makes the sample size a bit smaller than what is expected, because it is not 3,000 babies they are following up. They are this. And also one thing, as Dr. Elizabeth rightly told, they did not look at the children with both hypertension and diabetes, because that is going to impact the baby more. So that again the sample size became lesser, because that was not included. That common, they could have done a common combined hypertension diabetes babies and followed them up also, so to know whether that is going to affect them more. So that is what, so the sample size could have been larger. That is what I thought. Maybe that is exactly why they have kept that confidence interval very broad and wide. It is very wide. And so actually it's a very well conducted study, but the sample size is not large enough. So that's exactly where the conclusions was a bit shaky in this thing.
Slightly,
And though
yeah.
it has come in an AGOG and all everything, but it's a multi-centric, multinational study, that sample size might have impacted on the outcome, that conclusion, that thing. Only BMI was found to be, because we know for sure GDM mothers will have not just BMI high, GDM babies will have other risk factors also, cardiovascular high risk also. So that is it. And while findings are valid, so these are the 6 questions which we should ask. So again, the research question, you have looked at it very well and all. And so this is, and again, when you conclude, then when you go for the discussion, what we should think is, the first thing we should think is, can we apply it? Can we reproduce it in our practice? So when we look at it, yes, we can. We have so many GDM patients. We have so many hypertension patients. We just have to group them. We have to have a good study, RCT, and we might have a bigger sample size than this multi-centric study, because I'm sure most of the centers with more delivery rates, medical colleges, will have more than 300
Yes, I
GDM patients in
agree.
a year. And hypertension patients in a year. So this is a study. So whenever we look at an article, always think like a researcher. Can I do this research in my institute? So it's actually this really, actually we should, I think Dr. Shaijas selected this study. We should thank Dr. Shaijas for selecting this study, because this is something we can do actually in all our institute. So I think that is really, and thank you, Deepthi. You reminded me of the good old days when we used to
days.
present PG days. Okay. Thank you so much. Yeah.
Thank you.
Yeah.
Thank you, Dr. Sanjay.
I would like to tell you 2 points.
Yeah, please go ahead, madam. Please go
The
ahead.
short back of the study is they have started from the GTT at 24 weeks actually. It is
Yeah, yes, madam.
See, the IAD-PST criteria is actually when a patient first comes to the
at first visit.
you do a fasting blood sugar or a postpartum blood sugar, random blood sugar. If it is
Or HbA.
more than 126, she is diabetic. Advantage is we are able to detect type 2, undetected type 2 diabetes. That is again medium type 2. So that we are able to implement the treatment, and thereby we are able to reduce the morbidity and mortality. We have started this study here. Number 2, at what age the child to be assessed is not mentioned. The
10 years.
or the
10 years to 14 years,
10
madam.
years
10
to
to
14.
14 years, ma'am.
14 years.
10 to 14, ma'am.
10 to 14 years, ma'am.
10 to 14 years.
10 to 14. That's very clearly said.
Before 10, actually, usually before 10, the girls, especially girls, become obese. And the new later studies shows that even before attaining menarche, you start metformin, so that you are able to reduce the risk of even PCOS also. So we can start this study. Rashmi, if you are interested in this article with so much of criticism and points, actually you could have started the extension of this study in a different way.
Yes, madam. Actually, that's a very good suggestion.
Yeah,
Actually,
very
when you
true.
look
This
at
can
it
be done.
critically, there are so many, as Radhamani madam rightly pointed out, there are so many things. They just did the GTT at 34 weeks because for them that may be the norm because not many patients are GDM there. But here we do it in the first trimester.
Yeah.
And the cutoff is also a
First
bit
time
different.
And
we are doing every time first visit. We are definitely doing their blood sugar, HbA1c, and then if they are even obese family history,
And the
16 weeks we are
population
doing.
that they studied is also just the UK-based population.
It's not,
While
it's
the
not a
ethnic that she already
diverse population.
highlighted, so that makes a big difference.
Just a couple of points which I wanted to add actually because of the thought process behind choosing that article and all that. Just a couple of things. Now, when Rashmi was pointing about those this many points to analyze an article, I think I was reminded of all the good old days that we used to be a student and how good our teachers used to be. Though that point of time it was not enjoyable as today because now we are all settled. So even when you ask, it's all good to sit back and relax and relive those old days, though we didn't enjoy it much during those days. I primarily thought that the title of the article was much more appealing and promising than the actual study because if they had actually looked at the pre-gestational and the chronic hypertensive patients, the chances of it causing changes in the epigenetics and affecting the newborn on a long term was probably a most obvious result. When you consider that gestational diabetes is a short-term disease and a hypertensive disorder of pregnancy is something which is short-lived, if that could cause that much of changes as far as the epigenetics is concerned and still lead to a bad cardiovascular health in the adolescents, if they could prove it, it could actually be a path-breaking research in this front, actually speaking. So that's where this title appeared so very promising that they're actually not looking at a long-term disease. They're actually looking at two short-term disorders. One is gestational diabetes and the other is hypertensive disorder in pregnancy, excluding chronic hypertension for that matter. So it actually promised a lot. And as Rashmi rightly suggested, either we can look at good articles and then keep on praising them. Most of the other articles would tell you that you could very well do it in a much better way in your own center. So as they say, there is a lot of good things to learn from good articles. There is even more things to learn from a not so well conducted study or which actually promised a lot but actually could not deliver. And I think you're all in wonderful institutions, and we are all in a very in a great place called Kerala where academics is given so much of importance. And I'm sure we can actually take up these kind of researches and give more valid results. The only other point is ചിലപ്പോൾ കുറച്ച് പ്രായമുള്ള അമ്മമാരൊക്കെ പറയാറുണ്ട് പിന്നെ ഗർഭിണികളൊന്നും ഭക്ഷണം കഴിക്കുന്നില്ല, ഇവളുടെ ആരോഗ്യം ശ്രദ്ധിക്കുന്നില്ല. അവസാനം ഞാൻ പറഞ്ഞു, നീ ഭക്ഷണം നല്ലോണം കഴിച്ചിട്ടില്ലെങ്കിൽ നിന്റെ കുട്ടിക്ക് ബുദ്ധി ഉണ്ടാവില്ല എന്ന് പറഞ്ഞ ദിവസം മുതൽ ഷീ സ്റ്റാർട്ടഡ് ടേക്കിംഗ് ഇറ്റ് വെരി സീരിയസ്ലി എന്ന് പറയുന്നത് പോലെ ഫോർ ദ ക്ലിനിഷ്യൻ ഐ തിങ്ക് ദ കൺട്രോൾ ഓഫ് ഡയബറ്റിസ് ആൻഡ് ഹൈപ്പർടെൻഷൻ that it can affect the next generation is a very important point as far as your counseling part is concerned. So that could be from very straightforward counseling point for every practicing OB-GYN that a control of this disease in this particular generation can in turn may probably affect the cardiovascular health of the generation to come. I wish they could have proved it a little bit more better rather than just stopping at body mass index. And then that's why I told it promised a lot, but unfortunately did not deliver much. But I'm sure we are all in a better position to actually take up the study in a much better way and deliver much better results. And it would actually could be a path-breaking article if we can actually prove that a short-term disease can have a long-term outcome, like a bad cardiovascular health for the offspring that is born next. So that was my thought process regarding this article.
Actually, Radhamani madam, if we start now, 14 വർഷം കഴിയുമ്പോൾ we can publish it. Actually, we can publish it after 14 years.
Yeah, 14 years.
We have started this study. One of our assistant professor of nursing colleges at the hospital, 3 hospitals she is studying, but only the neonatal outcome based on this PGDM. Now, for example, the idea of till the adolescence we can continue. So at another study.
I'm sure. I'm sure that there are institutions where this study on the patient and the neonatal outcome, like in PIMS we have done that, and those will have the record. We can go ahead and trace those babies who are already now 10 and 14 and even more. So that is a possibility for medical colleges, have trace the previous research and then go forward.
But madam, that might become a retrospective study. We may not
No,
be able to.
it is prospective for the outcome.
Outcome prospective.
But then we had this HAPO study, right? Because the PIMS and Chennai was close, so we also published on this, and we found that there are a lot of pregnancy.
Trivandrum Medical College was one. I think, was it for MIC trial or HAPO? GMC Trivandrum was one of the participant institution.
So thank you all the experts as well as the presenter. I think Deepthi, you presented so well. Deepthi was very apprehensive on how Deepthi is going to be questioned in the question answer session. So I thought that she took that extra effort, which totally took away all the questions that could be asked.
Correct.
And experts had to really struggle to actually bring out new questions and actually ask her, because all questions were answered at the end of the presentation itself.
Thank you, sir. Thank you so much.
So on that note, thank you so much to all three of you, as well as the presenter Deepthi, for your wonderful inputs. I think it will pave way for future research. And I'm sure that one day one paper would come out from Kerala, and we would be cherishing that this was the starting point of all those good discussions that you have had in the years to come. So on that note, thank you so much, all of you, for being a part of it.
Thank you so much.
Thank you.
Thank you, Shaijas, and thank you, Agnes.
Thank you.
Reshmi, for those wonderful 6 points. I loved it.
Wonderful. And to the MOC Reshmi to take over the proceedings for the second session.
Thank you, Deepthi, for your wonderful presentation, and experts, Elizabeth Madam, Agnes Madam, and Reshmi Madam, for your thought-provoking comments. So moving on to the next session, introducing the experts of the next session. Okay, let me introduce Dr. Serena Madam. Madam doesn't need any introduction, but still it is my duty to introduce her. Madam is a professor and HOD, OBG Department, Jubilee Mission Medical College.
Reshmi, we'll move on, Reshmi.
Okay.
Yeah.
Okay. And
just tell only the name. Enough.
Yeah, I think that's enough. I think we have spent a lot of time on introduction. We'll go ahead.
Ma'am's introduction for a long time. Now, moving on to our speaker. May I introduce Dr. Atulya Shajan. She's a consultant, Department of Reproductive Medicine and Surgery, Saimar, Thrissur. Dr. Atulya completed her MBBS and MS from Jubilee Mission Medical College, Thrissur. Serena Madam's student. And she has different professional engagements. She has presented in FIGO and AICOG and participated in various national and state programs. Madam Serena Madam, may I request you for opening remarks?
Yeah. At the onset, I appreciate Dr. Shaijas for taking up this initiative. And I think that's one of the most important things, the Journal Club webinar series. I like the way he addressed Kunjumoideen SKM. And so, hi, Dr. Kunjumoideen, Dr. Subhash, Dr. Suchitra, all the senior faculty, my co-faculty, Radhamani Madam. And to say something about Atulya. Atulya has always been a very good student, a very smart PG, and a still smarter consultant. Now she will take us through this presentation and we will take it as it comes. Okay, Atulya, over to you.
Thank you, madam. Can I share the slide?
Yes, Atulya, you can share your slide.
Is it visible now?
Yeah.
Yeah. Is it moving?
Yes.
Yeah, okay. So thank you so much for the opportunity to the Kfog Research Committee and to all the senior faculties. A very good evening. I was given this very interesting trial, the Stopoxy trial. I would also like to apologize the noise disturbance. There's a concert going on in Jubilee right now. I'm very sorry. So the title was The Impact of Discontinuing Oxytocin on the Active Phase of Labor on Neonatal Morbidity, an open label, multi-center randomized trial.
So this was published in the Lancet in the 402nd volume on December 2nd, 2023. So oxytocin, we all know, is quite commonly used to induce and augment labor. The mechanism of action being it binds to the oxytocin receptors, activates PLCs, which catalyzes the production of inositol phosphate 3 that acts on the endoplasmic reticulum, that produces intracytoplasmic calcium, activates the muscle proteins and causes contraction. So in the uterine smooth muscles, it is associated with uterine contractions, and in the mammary glands, it causes the milk ejection reflex. So it is associated with uterine tachysystole. In turn, fetal distress and neonatal morbidity, and its effectiveness in reducing the C-section rates have not been demonstrated, and it also could potentially be associated with PPH probably due to uterine exhaustion and reduced responsiveness. So the STOP-OXY trial investigated whether discontinuing oxytocin after 6 centimeter cervical dilatation instead of continuing it till delivery would reduce neonatal morbidity while maintaining the labor efficiency. So prior studies suggested potential benefits of stopping oxytocin, but the evidence was inconclusive and was underpowered. Sorry, is the slide moving?
Yeah. Your next slide.
Oh, it's not going to the next slide. My screen is stuck. So sorry. Can I stop sharing and reshare again?
Yeah, sure. Right.
So the protocol assumption was that once women requiring oxytocin during the latent phase enter the active phase, natural oxytocin would take over. So they hypothesized that discontinuing oxytocin in the active phase will reduce exposure duration and the risk of neonatal complications without compromising the chances of vaginal delivery. So, going through the review of literature on the neonatal outcomes concerning the neonatal morbidity, only 2 trials were evaluated, and that showed an impact on the discontinuation of oxytocin on the rate of neonatal acidosis. 2 studies. One showed a 2-fold reduction in the neonatal acidosis in discontinuation of oxytocin, and the other study showed no significant difference between 2 groups when they considered the pH less than 7 and also the NICU admissions. And on maternal outcomes, the discontinuation of oxytocin groups, most of these studies, as well as meta-analysis, showed a longer length of active phase of labor, but none of these previously published trials showed an increase in the cesarean delivery rate. But on the contrary, a meta-analysis showed a significant decrease in the cesarean delivery rate in the discontinuous oxytocin group. And regarding PPH, 2 studies showed a decrease in PPH rates in the discontinuous oxytocin group without reaching statistical significance. The dose and the duration of oxytocin infusion is known to be associated with PPH. So by reducing the dose, we could therefore reduce the risk of PPH. Coming to the study design and methods. So this was a multi-center, that is 21 maternity hospitals in France.
Atulya, you can switch over to the PowerPoint mode. It's not in the presentation mode.
Oh, is it? Oh, sorry.
Yes, go ahead.
Yeah, thank you, sir. So this study was conducted in 21 maternity hospitals in France. It was a randomized controlled trial. It was an open label trial. That means there was no blinding involved here. It was purposely decided to not have blinding because while designing the protocol, they knew that if they had to switch the protocol between one group to the other, they had to know the identity of the investigators had to know which patient requires what intervention. Like for example, if the patients who were receiving oxytocin continuously, sometimes if there was fetal distress, they had to stop it, and the patients who were not getting discontinuous oxytocin, if they went into non-progress, they had to be restarted. So this had to be an open label trial for that particular reason, and this was a controlled trial. That means a control and intervention group was involved, and also a superiority one. That means they tried to prove that this intervention was superior to a continuous oxytocin trial. Discontinuing was superior. So the participants were 2,459 pregnant women, more than or equal to 37 weeks, at singleton pregnancies, cephalic presentations, who received oxytocin before 4 centimeter dilatation. So the indications to receive oxytocin before 4 centimeter dilatations were either induction of labor with or without pre-induction cervical ripening, or labor dystocia during latent phase when they came in spontaneous labor. So they were randomized into these 2 groups, that is continuous oxytocin group where oxytocin was continued until delivery unless there was any fetal distress or complications. And the other group was a discontinuous oxytocin group, where oxytocin was stopped after 6 centimeters dilatation, and it was restarted only if labor was arrested for more than 2 hours. Now, there's something called stratification. That is, in this randomization, they have not separated different centers and nulliparas and multiparas. They have collected the data separately, but they have not separately published it. So, the stratification by center allowed considering the possibility of variations in practices between centers, like, for example, epidural, the protocol. And the stratification by parity was needed because multiparas and nulliparas women differ on several endpoints, like the duration of labor and the mode of delivery. So, coming to the procedure of the trial, initial screening and the informed consent took place during the labor induction or the onset of spontaneous labor in the ward, and the informed consent was signed before including the patients, typically after onset of oxytocin infusion. And the participants were included if they received oxytocin before 4 centimeter dilatation, and randomization took place before reaching 6 centimeter cervical dilatation. And in all centers, oxytocin were administered according to the national guidelines, that is low dose oxytocin infusion, less than 4 units per minute with increments every 30 minutes without exceeding 20 units flow rate. Now, after randomization, in the discontinuous group, oxytocin infusion was stopped beyond cervical dilatation of 6 centimeters. And if necessary, the healthcare professionals were instructed that oxytocin can be restarted after 2 hours of labor arrest. That is, if there is no progression of cervical dilatation or fetal head descent. And in the continuous oxytocin group, oxytocin was continued during the active phase and during the second stage. And here, if necessary, it could be stopped because of an abnormal fetal heart rate pattern or uterine tachysystole. So this is why it had to be an open label trial with no blinding. So the inclusion criteria, women receiving oxytocin during the latent phase of the first stage of labor before 4 centimeter dilatation, including those undergoing induction of labor using cervical ripening or oxytocin, with a term pregnancy more than or equal to 37 weeks, singleton pregnancies, fetus and cephalic presentation, speaking and reading the French language, affiliated to Social Security, and those who have signed the consent forms. And those excluded were women with a scarred uterus, fetus with congenital abnormalities, fetal growth retardation with less than third percentile for gestational age, abnormal fetal heart rates at randomization, maternal age less than 18 years, and women participating in any other trials involving medications. So, we focus to measure the impact of discontinuation of administration of oxytocin during the active phase on the neonatal morbidity. That was our main objective. So this neonatal morbidity was measured as a composite measure, including the umbilical artery pH less than 7.1, a base excess more than 10 millimoles per liter, the umbilical arterial lactates more than 7 millimoles per liter, a 5-minute UPGAR score less than 7, and NICU admissions. So these were, or the composite measure of all these parameters were taken into consideration to measure the neonatal morbidity. The secondary neonatal outcomes were neonatal pre-acidosis, acidosis and its severity, which was defined as the COD pH in these ranges, that is 7.2, 7.1, and 7. And if there was a need for hypothermia for neuroprotection, any other neonatal complications requiring resuscitation, and the admission to NICU units and the length of hospital stay in the NICU unit. For the maternal outcomes, the secondary maternal outcomes were cesarean or instrumental delivery rates, labor duration, such as the median active phase duration, which was defined as a duration from 6 centimeters to full dilatation, any occipital posterior position at delivery, maternal complications like maternal temperature more than 38 degrees and postpartum hemorrhage were also considered as the outcomes, uterine tachysystole, and they also considered the birth experience and postpartum depression, which was measured using the labor agentry scale and the Edinburgh postnatal depression scale. So the labor agentry scale was evaluated at second day postpartum, where the higher scores indicated a greater sense of control during the birthing process. And after 2 months postpartum, they used the EPDS, that is the Edinburgh postnatal depression scale, to assess the women's well-being, and this was done via email. They communicated via email, and a score of 10, greater than 10 on the EPDS scale was indicative of a higher likelihood of experiencing depressive symptoms in these patients. So now coming to the statistical part of the study. So there are different types of analysis approach in the study. So the first one was the intention to treat population, which is the entire population that they recruited for the study who consented and those who withdrew were only ineligible. Those who consented for the study were all part of this ITT, that is intention to treat population. The modified intention to treat population was a subset of this ITT population that included participants who reached at least 6 centimeters cervical dilatation. That is, at least they reached the criteria for inclusion. And those participants were excluded who withdraw consent or who had a C-section before 6 centimeter dilatation. So this was a smaller number compared to the intention to treat population. And this modified intention to treat population was actually the primary analysis of this study. The third type of analysis approach is called the per protocol analysis. Per protocol analysis means the participants who only very strictly were adherent to the intervention as part of the study protocol. This is an even smaller number. So the statistical approach was a modified intention to treat analysis, which excluded those who did not reach 6 centimeter dilatation. And the sample size was calculated initially. That is, the 2,250 participants were the intention to treat population, and the 2,170 participants were the modified intention to treat population. So this was the trial profile. Here, they first included 2,493 participants, and 34 were excluded who did not meet the inclusion criteria. 1 withdrew the consent, and 7 other reasons. So this total number was the intention to treat group, all the people who were recruited in this trial. After which they were assigned, randomized into the discontinuous oxytocin group and the continuous oxytocin group. And this randomization, they used a 1:1 allocation. That is, if one patient was assigned to discontinuous oxytocin, the other one assigned to the continuous oxytocin. And they excluded those patients who, before delivery, those who met the exclusion criteria, and also those who underwent C-section before 6 centimeter dilatation were also excluded. That is how they got the modified intention to treat population. So this is the number of the modified intention to treat population which was included. And they assessed 918 women for the labor age entry scale. 657 were assessed for the Edinburgh postnatal depression scale. Similarly, on the on this side, where the continuous oxytocin group, they had 1,103 in the modified intention to treat population. So out of which the 9 participants who did not receive the assigned intervention were excluded, and those who very strictly were adherent to the protocol, which was called the per protocol population, was included. So these 3 types of analysis was done in this particular study. That is 3 types of approaches: ITT, MITT, and PP. ITT and the per protocol analysis they have published in the appendix, but the primary analysis that they have published in the study is only the modified intention to treat analysis. So these were the results. So the outcome categories, the primary outcome was a neonatal morbidity. In the discontinuous oxytocin group, it was 9.6, and the continuous group, it was 9.2. And the difference was only 0.4%, which was not statistically significant because the confidence interval was between -2.1 to 2.9. And the mode of delivery, that is the cesarean rate, was also not statistically significant. The labor duration that from the active phase to second stage to the delivery showed a significant mean difference, that is 100 in the discontinuation, 90 in the continuation, 120 minutes in the discontinuation group, 83 in the continuation group, 244 minutes in the discontinuation group, and 193 in the continuation group. And the uterine tachysystole, that is hyperstimulation, in the discontinuation group was only 6.3%, but in the continuation group it was statistically significant, that is 10.4%. And NICU admissions did not show any statistical difference. Apgar scores in the COD PH also did not show any statistical difference. The labor age entry scale and the Edinburgh postnatal depression scale did not show any significance. But the neonatal morbidity, there's something else called subgroup analysis. Like we said, there was a stratification that I mentioned before. That is, they did not include parity and the center. So parity and the center, they had collected the data, and this is why they needed it. That is for subgroup analysis. So subgroup analysis, they published neonatal morbidity in multiparous women separately. That showed a significant difference in the discontinuation group, which was much lesser. That was only 5.6%. The postpartum hemorrhage and the maternal infection rates were also not significantly different in both groups. So to summarize the key findings, the primary outcome, that is a neonatal morbidity at birth, was not different. There was no significant difference between the two groups. That means discontinuing oxytocin did not reduce the neonatal morbidity. And the secondary outcomes, that is the C-section rates, showed no significant difference. The labor duration showed significant difference. That is, discontinuing oxytocin led to a longer active labor and second stage. Uterine tachysystole was lower in the discontinuous group. And other maternal outcomes like PPH and infection did not show any major differences. And the subgroup analysis showed a higher neonatal morbidity in the discontinuous group. That was 5.2%. So the study strengths were that it was a large trial to date that is comparing continuous and discontinuous oxytocin on neonatal morbidity as such. And it is a multi-center design that enhances generalizability. And it used a very robust statistical method, that is a modified intention to treat per protocol analysis and the subgroup analysis also. The limitations were that it was an open label design with no blinding, because so in that clinicians knew the group assignments, and that possibly affects the management. And a higher oxytocin restart rate was also observed in this discontinuous group. That could have reduced the differences. And also post randomization exclusions, that is 92 participants were excluded after randomization. That could have also affected the group balance. And also the long term neonatal follow up was not observed in the study. That was also a limitation. So to conclude, among the participants receiving oxytocin before 4 centimeters, discontinuing oxytocin after 6 centimeters did not significantly reduce the neonatal morbidity compared to continuing it. But uterine tachysystole was reduced, suggesting potential safety benefits. And this study highlights the need for future research on individualized care, patient-specific factors in our obstetric practice. Thank you.
Thank you, Dr. Tulya. That is a very nice presentation. You brought out every aspect of it and very beautifully explained. Now, I'll just take you through 10 points and make the whole study very simple for you all, okay? So this was actually, as Atulya said, it was published in the Lancet of 2023 December. Now, whenever a publication comes out in Lancet, BMJ and all that, they always have a prior protocol study published. And
Atulya,
so
you can stop your screen sharing if you
Yes, yeah.
Yeah.
So
Madam,
right
please
enough,
continue.
yeah, right enough, they've had a protocol study in 2020, which was published in an earlier publication. And after that only they have taken up this. Now, what did they do? Now, if we try to simplify, she said it was called the stop oxy. That means they stopped oxytocin. Okay, and it was a multi-center because 21 centers were involved. It was a randomized open label, meaning the researcher and the person, the person, they know the treatment. You understand what treatment they're going to give. It is not blinded. So the researcher and the participant will know what treatment they're going to give. So it was an open label and it was a controlled trial. It was a superiority trial. It was not a non-inferior trial, but it was a superiority trial to show. That means their expectation out of this trial was also fantastic, but it did not reveal anything much. That was very, very unfortunate. Now, what did they do? They tried to stop oxytocin. So basically, they were all patients who were on oxytocin. Okay. So from 4 centimeters onwards, before 4 centimeters, they were on oxytocin. And at 6 centimeters, that means the active phase, they stopped in one group. Okay. And in another group, they continued oxytocin through the labor and delivery. Okay. That is the second thing. The third thing they looked only at the neonatal morbidity. They did not look much at the secondary outputs. They looked only at the neonatal morbidity. Why they did that? Because then their sample study would be less. If they had looked out for what their secondary outcome would have been, the samples of the study should have been very large. You understand? And what did they see? Stopping oxytocin, did it affect neonatal morbidity? And what did they check out in the morbidity? They checked out to see whether the baby was acidotic. Okay, they looked at the umbilical cord, arterial pH, the base excess, the umbilical cord lactate, and the umbilical artery lactate, the UBGA score, and the neonatal admission. That was a composite. So if any baby had any one of them, they were included as a neonatal morbidity. Do you understand? So their main aim was to stop the oxytocin. So one limb continued and one limb stopped oxytocin at 6 centimeters. And the other group continued through labor and delivery. And as Atulya rightly said, why they gave so much of importance to stopping oxytocin? Because they said that when you continued oxytocin, 30% of women actually had tachysystole. And whenever there was tachysystole, it did affect the neonatal outcome. You understand? So that was the reason why they stopped the oxytocin, and they wanted to see the outcome. But in fact, they did not see. The earlier studies also they had done a smaller study, 100 and 300 and all that. In that, they noticed that there was some benefit in the neonate. But then they said the study was so small. They said it was underpowered. That is why they took on this study. Okay. And then, as she rightly said, they have started on oxytocin. Their main aim was to study the impact of discontinuing oxytocin versus continuing oxytocin. Simple. Their exclusion criteria, as she said, any scarred uterus, any congenital abnormality of the thing, any abnormal fetal heart rate, all those people were taken away from the study. They gave adequate counseling. They counseled them through the antenatal period. They gave them pamphlets and counseled them. They did all the counseling, but the consent was taken only after the oxytocin was started. Okay, so that was okay. That is fine. They took the consent and they randomized only after 4 centimeters. Okay, they did the randomization of the stop oxytocin and the thing. And as she rightly said, they have done the low dose protocol of oxytocin. But one very, very important thing, which she said that, I don't know whether you all understood that, those whom they stopped the oxytocin, you know, they had to restart in a small, about 439 people, they had to restart the oxytocin. Do you know why? Because they found that the labor had come to an arrest. There was no further dilatation. There was no further descent. So they had to restart. Now, that was one of the pitfalls of the study. And in the other continuous group, they had to stop the oxytocin because they noticed that the baby was having abnormal fetal heart rate and tachysystole. So you understood? So though their intention was there, they had to restart in the stopped oxytocin and they had to stop in the continuous oxytocin. And look at the number of people which they wanted to treat. The number of people they wanted to treat was 2,250. That was what they thought of. Okay. And they wanted to put 1,125 in the continuous oxytocin and 1,125 in the stop oxytocin. Then what they did was they added a 10% more. Do you know why? Because there were a lot of dropouts, no? So because of that, that was a good thing. They added a 10% to the total strength of the numbers, and they had to bring it down up to 2,475. So from 2,250, they had a very good total of 2,475. But what happened? Many of them dropped out. That was the next pitfall of their study. As she said, their intention to treat was in the 2,475, but the modified intention to treat dropped out because many of them had to get out of the study for many reasons. As she said, you know, some of them did not want, some of them had required a cesarean before 6 centimeters, some of them, you know, had abnormal fetal heart rate patterns and they had to do sections and all that. So there were a lot of dropouts. And in the end, do you know how much their study number was? It was a very meager sum of 2,170. That's all. So where it should have been 2,400, that should have been the correct population to treat. They had only 2,170. And that they divided. And that divided into one arm of 1,067, which stopped oxytocin, and 1,103, which continued oxytocin. So totally the strength, the power of the study dropped. Do you understand? Then what happened was, as they were observing, they also noticed, so there, one was they had to restart oxytocin in some, they had to stop oxytocin. The second one was the number, the modified intention to treat dropped from a big number by over almost 300. It dropped down. Okay. The next thing what they noticed was, in the end, their assumption was that the neonatal morbidity was about the same in both. It was 9.6 in one and 9.2. So the difference was only 0.4. So whether they stopped oxytocin or whether they continued oxytocin, the neonate did not benefit. But what else did they look at? They looked at some other things. They noticed that there was an increase in the cesarean on those who stopped oxytocin. You understand? Which is very contrary. Why did they have to? There was an increased incidence of cesarean. So what they said was, by stopping oxytocin, we did not decrease cesarean. So how they put it? By stopping oxytocin, they have not decreased the cesarean. In fact, when they noticed there was a slight increase, in fact, it was more in the multiparous women, they noticed there was increased incidences. So forget about the neonatal morbidity, there was absolutely no difference, only 0.4 difference. And in that, so they said one thing, that there was no decrease in the cesarean rate by stopping oxytocin. So they made it another thing like that. And they also said by the reduction, the total number of the neonates, they said that there was a reduction in the tachysystole, okay, when they stopped the oxytocin, but that did not extrapolate to betterment in the neonatal outcome. You got that? They always thought that when they stop the oxytocin, or tachysystole would be stopped, and thereby you will get a better neonatal outcome. But though the tachysystole stopped, they did not get a neonatal outcome. So these were all the drawbacks of their study. So if you try to see the drawbacks of their study, I will sum it up as saying that they started with a big number, but their modified intention to treat dropped dramatically. And so much so, only 1,069 took part in the stop oxytocin, and only 1,103 in the continuous oxytocin. There was increase in the cesarean rate in the discontinued to 9.1, whereas those who continued oxytocin, there was only 7.1. So they put the interpretation as it is not statistically significant, but by stopping oxytocin, the cesarean section rate was not decreased. See how they manipulated the thing. So this is similar to a Danish study which came out earlier on. And a Danish study also, they had said the same thing. So when you try to see overall, the two main drawbacks were the number of people in the study reduced in the end because of all the dropouts for whatever reason. And the second one was that they had to give oxytocin in those who had stopped, and they had to stop oxytocin in those whom they had given. So this is how I would sum up in the saying that this is an area of further research, and that is how they have also stopped there. And imagine a publication in the Lancet to say that this is, they have said particularly among nulliparous, and there's a large number of induction patients, but the study highlights the need for further research on individualized care and patient-specific factors in obstetric practice. They have concluded their study like that, though the inference is very meager. Okay.
Ma'am, also it was very confined to the France population, only in France.
Only in France.
Thank you so much.
That has got its plus point also, Molay, because there was no ethnic differences. That was one plus point. But the negative point was whether we can extrapolate to other population, we do not know.
Thank you. Thank you so much, Serena Madam. I think the effort that you take, no wonder these champion teachers will still remain the favorite whenever it comes to a journal club discussion. I'm not telling this for the sake of telling, but the enthusiasm which Madam is showing to actually reach out into the depth of that article and analyze it and make it as simple as it can be. I think that effort deserves a whole lot of appreciation. I just want to put in 2 points of discussion before I get into Radhamani Madam. One is, Madam, 1 second. Yeah, I just want to put in 2 particular points in front of Serena Madam. I think we are all worried about the increasing cesarean rates. Now, this induction has been shown to be, or at least believed to be by some, to be one of the culprits for the rising cesarean sections. And that is why there are a whole lot of modified protocols that are being set in. People who are taking it very slow as far as their induction augmentation process is concerned, taking it over a period of 24 to 48 hours on a very slow basis, so that cervical ripening, and then there is time given, and then there is an augmentation that is started if required. So people are getting very judicious as far as the use of induction and augmentation agents are concerned. Now, I want to know what is your take on that induction being a culprit, induction augmentation policies being a culprit for increasing cesarean section rates. And number 2, if the numbers could have been more, that particular reduction in tachysystole because of stopping oxytocin, whether it could have translated to better neonatal outcomes was the second part of the question which I wanted to place in front of you. And after you answer that, we will switch over to Radhamani Madam and take her inputs about how this article has been.
Very good. Thanks a lot. Those 2 very important points. One is whether induction is responsible for the, there is not 100, but 200%. I agree with you. I think we should not be inducing left, right, and center. And after the ARRIVE trial came up, when they could be induced at 39 weeks and there was no, that was only a stopgap. That does not mean that we should be inducing our patients left, right, and center. There have been centers now, even in Chennai, they've been doing studies in which they've allowed the patient to go as far as 40 weeks and then they're thought of induction. In that, their incidence of cesarean has dropped dramatically to 15 to 20, 21%. So that is a culprit. I not 100, but 200% agree with that. The second part, whether if we had increased this particular thing, I do not think it would have made any difference. Whether if the number of it would have powered the study and it would have made it statistically significant, but I don't think the outcome would have changed. I do not think. Thank you.
Okay. Thank you so much, madam. Over to Radhamani, madam, for your inputs.
Both Adilya and Sarina have completely scrutinized even the numbers, everything. But the only thing, 2-3 drawbacks only I would like to tell you. That tachysystole with the fetal heart deceleration is either it is hyperstimulation, they have not mentioned, it is only tachysystole. So tachysystole plus non-rational fetal heart is hyperstimulation. Number 2, in one area they said discontinuing oxytocin, the incidence of PPH is less. Whether you agree, Sarina?
Discontinuing oxytocin?
Discontinuing oxytocin, the incidence of PPH is less.
No, I do not think.
Yeah, it is here in the paper.
Yeah, that is what the secondary outcomes is a lot of controversy.
Yeah, a lot of controversy.
Lot of controversy.
Another most important factor is after 2 hours of stopping oxytocin, they have started. What is the reason why the contractions stopped? They have not ruled out whether it is a CPD or an oxytocin position. These are the 2 conditions where the contraction stops. That also not mentioned.
But they have said that it is due to arrest. Arrest, either it could be arrest of dilatation or arrest of descent, but they have not specified, as Madam said. They have not specified. They have not specified.
Another thing is, in centers like us, whether intrauterine fetus is having cardiac disease, and we need to deliver the fetus before 5 o'clock, before they go. We have to continue oxytocin and deliver the fetus because daytime is needed for the baby. We need to transfer the baby to the cardiologist and also to the neonatologist. That is the reason why continuation. Discontinuation, I finally said, they said discontinuation or continuation, the same result, and more research is needed. The importance of what we get is by scrutinizing these journals, we get more idea about starting another publication. That is advantage. That's so I thanks Kunjumaideen and Shaijas and for because they have proved their excellence. So actually, this is idea, the great idea that we get how to scrutinize and also to get into another research area to get more points. Because we have more points, but we are not writing. That is the important.
Madam, when they discontinue oxytocin, there is no tachysystole, and they say endogenous oxytocin will take over. I don't think, yeah. I feel once you start oxytocin, you are committed. You have got to deliver it in the end. As she said, PPH is there. Yeah.
Oxytocin നിർത്തിയ tachysystole എങ്ങനെ വരാനാണ്? നമ്മൾ എങ്ങനെ വരാനാണ്? അതൊക്കെയാണ് അന്നേരം ഇത്രയും മണ്ടത്തരം എഴുതിയിട്ട് ലാൻഡ്സെറ്റ് പബ്ലിഷ് ചെയ്തിരിക്കണം.
അതാണ് ഞാൻ പറയുന്നത്. There is no outcome on this study. It has left the person so confused whether to continue or discontinue, and we have come to the decision best to continue. And they have looked only at one aspect, only neonatal morbidity, discontinuing and neonatal. They have not given it much importance at all. So it's very surprising, Madam പറഞ്ഞ പോലെ ഇത് ഇത്രയും വലിയൊരു നമ്മൾ ഇതിനേക്കാളൊക്കെ എത്ര കൂടുതൽ ചെയ്തിട്ട് we are fools because we don't publish what we do.
Yeah, that is a great disadvantage of us. So but the only thing, Sarina, those who are working will not get time. Those who are not working will get time.
But I think we probably have to get over that excuse and actually start bringing out more studies, I believe.
You get more ideas. That is so I thanks to both all of you, because this is a great opportunity to scrutinize and also to get idea to start another publication. That is the research area. So actually today only we got a paper from the director. What are the research areas are we are getting into? So I can write this also. Research.
Thank you. So I think thank you so much, Atulya, for that wonderful presentation. Thank you so much, Serena Madam, for always being so wonderful, so diligently scrutinizing that article and bringing out some great take-home points. Thank you, Radhamani Madam, for your very valuable inputs and being here even at the fag end of this evening to be here with us, joining the discussion. And thank you to all the other faculties who have logged in and made this discussion a very, very enriching one. Over to Reshmi for the vote of thanks before we finish the program.
Thank you,
And
Kfog, for
I should thank Shaijas for this wonderful initiative.
Thank you, madam. Thank you so much.
Thank you, KM sir, for your initiative and leadership. Thank you, Subhash, for always being so hardworking and dedicated. And congratulations and thank you, Shaijas, for yet another successfully completed event as academic coordinator. Thank you, Sujitra Madam, for being a team leader and motivator. Thank you, all the presidents, for being here with us today.